So, as they say on Blind Date from the 1980s, what's your name and what part of West Yorkshire have you arrived from?
My pronouns are she, her, if I've got that right.
Yes, well done.
My name is Emmeline, if I'm naughty, and I'm the head of Improving Population Health. Which part of West Yorkshire have I come from? Technically, I live in Kirklees. I've come from Wakefield today, though, because I was in the office delivering training this morning.
I did. I saw on Twitter. Very excellent work there.
Yes, it's exciting, and I work across West Yorkshire.
Awesome, and we're very, very blessed to have you. Another person I'm very blessed to have in my life is Kenise Khan. Do you want to introduce yourself?
I'm she, her as well, and I'm the chair of the CSE Voices Group panel for West Yorkshire Health and Care, and I work for an organisation called Wellsprings Together, and through that work we're doing the review on race equity for the whole of the partnership.
Awesome. Moving on, there is another legend on this podcast. His name is John Ebo. John Ebo, do you want to introduce yourself and please make sure that you mention your pronouns, please?
Indeed. Pronouns he, him. Name John Ebo. Real privilege to be here. Really pleased to be with everybody this evening. I'm the head of Equality, Diversity and Inclusion at the fabulous Leeds City Council. So which part of Yorkshire am I from? It can only be one place, right? The capital of Yorkshire, Leeds. There you go. I've said it.
I mean, I could comment, but we're live. George, do you want to introduce yourself?
Yes, so my name's George. I use they, them pronouns, and I coordinate a network called West Yorkshire Voice. So I work across West Yorkshire, but I'm based over in Leeds.
And we're really lucky for you to join us. My name is Fatima Khan Shaun. Our pronouns are she, her, and I am proud to be the first ever West Yorkshire Inclusivity Champion. I am really delighted to be hosting the Can You See Me podcast operating live. For those of you that are familiar with the podcast, you'll know that this is a really interactive, both video and audio based podcast. And we do have a back catalogue which you can check out, exploring topical issues relating to inclusivity and diversity. As you can see, this is the first ever time we've done a live podcast, and actually, if it goes all right after the little bit of a accidental beginnings, then we might do this again, she says. I can see Ben sort of shaking with terror at the prospect. But the reason why we wanted to facilitate this conversation was we wanted to do something that was proactive and impactful and starting to facilitate a conversation with our communities about the concepts of equity, equality, social justice, inclusion, and what it actually means. And what we're hoping to do today is to facilitate a little bit of a conversation with some of the panel members, but also via the technical genius of Colin, who I believe is on the call. Colin, do you want to turn on your camera and introduce yourself? We will also have an interactive element where people can comment in the teams, and you can then share to us what the social media networks and the comments are coming like via the medium of technology. Is that right, Colin? Have I summarised that correctly?
Yep, that's perfect. So at the top
Awesome.
of the screen, people can see that there's a Q&A button. So if you click on that, you'll be able to post your questions in there. And we've also got Slido links that will seamlessly appear for people to join in as well.
Awesome. And as they say in the NHS, it's an evergreen offer, right? So we might be recording live tonight, but if you think about something at 2 o'clock in the morning, don't call me. Use the QR code on the Slido link and send it in to us so we can make sure we capture it and it's a part of the conversation. So I'm going to start with, I think, a really hard question. And I'm going to come to you, John, with this first question, which is, if by the magic of being able to change one thing about the services we provide in West Yorkshire, both health and care, to make them fairer for everyone, what would you do and why?
Thank you, Fatima. That's a bit of a question, isn't it?
It's a beautiful question. It's a hard question, though, John, because I'm saying one, not 10, one.
One. I guess the very definition of equity is about treating people according to their needs, right? That's how we define equity. So I guess one thing I would particularly want to look at is something around cultural competence. And we often talk about this, but we don't really kind of take it seriously, or for some people, it sounds very complex. It sounds a bit scary. But I think the one thing we could do better at is meeting people at the point of their needs. And that is understanding them at the point of their cultural need. And the way we receive services, health and care, will vary. I mean, the medical treatment might be the same, the social care might be the same. How we get that treatment to people will probably be, I suppose, shaped by culture, where they're from, who they're comfortable with, all that kind of stuff. So there's always work to be done around making sure all our services, including our staff, our colleagues, are culturally competent in delivering health and care. I think that's probably a good starting point.
It's a good starting point and a beautiful segue to Kenise, because this is Kenise's bread and butter. I mean, she does cultural competence for breakfast, don't you, darling? What are your thoughts on John's answer? And do you support his suggestion, or would you suggest something different?
No, but I would add in about the lived experience, because the lived experience part with cultural competency, unless people can share what their lived experience of our services are, and then they're acted upon and their feedback is acted upon, we're not going to make loads of difference. So we should have the cultural competence, but where's the lived experience? And I suppose I'm going to speak from the perspective of the VCSE and faith sector as well, because that's where I come from. That's where my real bread and butter is as well, my weekly one. And I would say this principle of subsidiarity, are we actually using it? Have we got our services closest to the ground, to the people that are living in our communities? Like, for example, everyone knows what's recently happened in Hare Hills. How close were the services to Hare Hills? Do they know those communities? Do they know what their norms and their values are and how they live? Do they have people that represent those communities do they have a voice within the system?
Yeah.
So I would think about how close we are as a health and care sector to the ground, to the communities that we're working with, because we've got so many different communities and so many different, there's 9 inclusion factors as well. So there's disability, there's what are those experiences? So I think that's from my VCSE sector.
I mean, the thing is, we should have like a podcast bingo or a podcast glossary, because we're talking about subsidiarity, and some people that might have joined the podcast are like, what is that word? What does it mean? So subsidiarity is a word we love in West Yorkshire's Health and Care Partnership. If my boss, Rob Webster, was here, it'd be a word that he'd have said in the first 2 minutes. And basically what it means, it's a very logical way of thinking, and Rob is a very wise and logical man. It means delivering services as close to people as possible. It means putting resources as close to people as possible, and using people that live within the communities, are trusted by the communities to deliver those services. So, beautiful ethos, but sometimes the word people don't understand. And the other thing you said, Kenise, which I completely agree with, is the power of lived experience, right? So I started my whole journey as a lived experience advocate. I was that annoying woman at public meetings trying to make change happen. And the thing is, your lived experience is really emotive, it's trauma informed, it can be quite triggering. So leading in that vein can be quite challenging, but actually if we harness it properly and we amplify it, it can be quite cathartic as well. And then coming to you as the guru of trauma informed working, we've done so much stuff in this space, but there's probably more we could do, right?
So much more. And actually it needs to start with our workforce.
Yeah.
Because we've got to care for the people that care for the people. And if we don't do that and we don't get that right, then we're not going to make the changes that we want to see. So absolutely, there's lots of work we can do around our organisations being trauma informed, but we need to be a trauma informed system, because our communities, our organisations and individuals experience trauma. And EDI is at the heart of that. Because ultimately it's all about connections, it's all about belonging, it's all about relational wealth. And if we don't have those and we don't celebrate diversity, then we'll never get the trauma-informed response right.
Absolutely. And one of the things that we need to acknowledge is when we use the term system, which is another ding, 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 bingo word that we all use, what we mean by system is the Health and Care Partnership, which is a group of organisations that both commission and deliver health and care services, our local government colleagues and our incredible friends in the voluntary community and social enterprise sector. We're all part of one system and the same. Part of our VCSE sector is the Incredible Health Watch, which talks about and amplifies the lived experience of people. George, you talk to people all the time. If they asked you one thing they'd change, what would it be?
So I think a big thing that we hear time and time again is communication.
Yeah.
Communication is key to everything, and it kind of relates really strongly to what you've just said around language and people not always understanding what we're talking about as a health and care system. So it's really important for us to think about how we communicate with people accessibly, and also just for everybody, it would make it easier if we were using more simple versions of communication. The average reading age, according to a study in 2015, is between 9 and 11 years old. So we should really be pitching everything we're saying, everything we're communicating with anyone, even colleagues. We have a habit, even within different health and care services, of communicating in jargon or in acronyms, and it's really important to be accessible for different people, and that includes different forms of communication within the accessible information standards, so using things like Braille, using easy read, large print, and unfortunately a lot of people are still receiving information in a format that they can't understand. So for example, people who are blind or partially sighted receiving letters that they can't read, or people who are deaf or hard of hearing being asked to ring the doctor and have a conversation. And those are things we should be getting right at a basic level.
Absolutely. And did you want to come in on that before I move us on?
Yeah, I think I completely agree with everything George just said. And literacy poverty is huge across our system, and we see that in our population.
I think my literacy is about 5. Like, not gonna lie.
But it's not just literacy in relation to reading and writing, all of that as well. It's health literacy.
Yeah,
and actually what we find is that people can navigate the system that have got good health literacy and they get the help that they need. And then we refer to people as hard to reach, but they're not hard to reach. We just don't put the right effort in. Exactly, I hate it.
In West Yorkshire, you're not allowed to say people are hard to reach. You're not getting to them, which is a different thing.
Exactly. So there's big things, I think, around that, but language as well, and just bringing that in, that the language that we use is so important. It can be harmful, it can be healing. And if we want to get this right, we've got to take all that into account.
George, did you want to come back in? Because I've got some comments in the chat I wanted to come to, so very briefly.
Yeah, it was just to add to that around choice as well, because I think I know for myself, using health and care services is the thing in your life that sometimes you put off, that feels quite difficult, quite sensitive, quite emotive, and it's the thing that if you don't have an easy way of getting it or communicating with services that makes sense for you. Someone mentioned about neurodiversity. It's really anxiety inducing for people to phone a service a lot of the time. I know I find that as somebody with ADHD, that I either forget to do things or I find it difficult to communicate with services. So it's important to have that choice as well.
So culturally competent, trauma-informed, accessible services, bang, done. The thing about neurodiversity as well, and thank you, Yasmin, for putting that in the chat, is, if you have got dyslexia, a letter probably isn't the best way, especially a letter that's on, a white piece of paper. It's just going to make life a lot harder, isn't it? But Colin, going straight to you, our guru on the social media and interactivity stage, what are our colleagues saying, reflecting in the forums? Oh, look at that's beautiful. What does it say?
So we've had lots of people take part in the Slido poll. If you do want to take part, please do click on the Q&A and all the links are there and you can add your comments in. It's really reflecting a lot of what's been said already.
It really is, isn't it? Clear
the biggest
communication.
one.
People talking to each other across organisations. What a radical suggestion. That's just nuts. That is services considering the needs of everyone. Awareness of, these are all really radical suggestions. I'm not sure that this is something we can consider. And also treating everyone equally. I would challenge that back slightly, because equality talks about treating everyone the same. And actually, if you talk to Emma Irving or you talk to Kenise Khan, they'll say to you that actually treating everyone the same probably perpetuates the inequality. What we need is something specifically targeting the needs of individuals. A radical concept called personalised care, which is alive and well in the West Yorkshire Health and Care Partnership. Thanks, Colin. I'm going to move us on to the next question that we're asking colleagues on Slido. So this is another one that people can interactively communicate with us on. And it's question 3 for our panel members that you've seen previously. And it links back to something that you said, Kenise, particularly, which is, how do you make people feel seen and heard? and represented in health and care services, particularly when they're advocating about their own lived experience, because that's really hard. And when you're talking about cultural competence or experiences that you've had, and the people within the organisation, because they can't relate to that or they don't understand it, aren't giving you the response that you need, that's really difficult, isn't it?
So it is about being culturally sensitive, being culturally competent in that way. But I suppose even using the words, so you're talking about understanding words, using the words of culturally competent, what does that mean? But actually, it's all about how inclusive are we of everyone and their quirks and their norms and their habits and their abilities and their neurodivergence in every single way, shape, and form. But I think what we do need and what we have not got is representation in our organizations at every single level that represent all these different areas that we should cover. And I know we're not going to get everyone, but we need people that look like us who are sitting on boards. We need people and our executive directors. We need chairs in our system that look like us and can understand us. And also there's something about the people, coming back to people, I think was really, really important that I'm quite advocating strongly for with Leeds and York, because I'm also a non-executive director at Leeds and York Foundation Trust. And within there, I'm advocating for the voice of our bank staff, simply because they don't have the stability, and our agency staff, they don't have the stability and might not take the risks to speak up about environments that might not be safe, or they might not feel safe, or they want to say something, but because they might not get the next shift, they might not feel like they can speak on it and are scared and fearful of not getting the shifts. But actually, they're the ones that are at the probably at the poorest end of our communities, probably work 2 to 3 jobs, and need our support the most. How can we make our environment safe for them to speak on what's happening on the ground? Because we can sit at board level. How do we know what's going on our wards? We can't, we don't. We can do our visits.
I mean, so there's the principle of nothing about me without me, right? Because that should always be a principle that any inclusive leader should think about. But there's also something that a legendary gentleman called Michael West, Professor Michael West, always says, which is listening with fascination. And if you think about studies that people do, quite often when people are listening to a conversation, and I never do this for you, Kenise, but quite often what people do is they're waiting to come back in. So they're not really listening to what you're saying, they're waiting to respond. And actually, to truly involve people, to really amplify the lived experience of people, you've got to really listen to what they're saying. And sometimes the way that they're saying it may impact their message, but you've got to park that, because actually they might be impacted emotionally by what they're trying to tell you, but they're trying to help. And there's some reflections in the chat about cultivating belonging, about caring with curiosity. Absolutely. But there's also something about the dynamic of power, giving power back to the patients to come up with the solutions, because most patients that I encounter are really intelligent, far more intelligent than me. You can have an adult conversation with them about what care they need, and they can fairly articulate what it is that they want as well. And there is a principle, and Yasmin put it in the chat, of shared decision making, which is, I know, a really radical concept, but actually is something that many clinicians who are worth their salt absolutely amplify. John, as somebody who works in local government, this is something that you do on a day-to-day basis, right? This is how you roll, my friend.
Yeah, thank you, Fatima. No, I was going to speak to the word heard, and you kind of touched on what I was going to say. So I mean, the two bits that seem to me that question were around feel heard or not heard.
Yeah.
And there's a simple answer to both, because actually in all of that we need to listen to understand. And I think quite often, I'll be careful what I say here because I do work in local authority. There's a C word, right? We do consultation when we want to listen.
Oh,
Apparently.
can't believe you said that on a live podcast, John. Consultation.
But sometimes, that consultation is done with an end in mind. So, sometimes organizations already know what they're going to do. And they do this consultation piece, and it just to fit the outcome that they want. I'm not saying we do that here in Leeds, no way. I'm just saying that actually when we do consultations, they should be done properly. We do it genuinely. We do it to listen, to understand, and therefore act on what people tell us. There is no point in asking a question if you feel we do anything with the answers.
I mean, do services do that, John? Surely not.
Well,
Surely not. You know, I've got another C that I want to share with the panel. I'm going to ask you this question, Em. Have you heard of something called co-production? Really radical concept. Radical, I know. Is that
You've
something
done
you've
that
ever
on-
encountered?
You've done that on purpose, haven't you, Fatima? Yeah, I mean, yeah. Do you know what? I'll always go back to the ladder of participation, because
Oh
we
my
have
days. We're
to.
going back like
We are.
decades now of
We are. I'm
involvement
showing my
theory.
age. I'm showing my age. I was a youth worker for 12 years. Consultation has a place. Collaboration has a place. Co-production has a place. What we need to do is ask our population how they want to engage with us, because actually we make assumptions. We make an assumption that everybody wants to co-produce. Not everybody wants to co-produce. Some people just want to give their opinion. Some people just want to be part of the conversation. So I go back to that ladder of participation, which is whenever we're starting something, let's ask our population how they want to be involved. But let's not just leave it at our population. Let's also do it with our staff. If we want to show compassion, if we want to be inclusive and equitable, we have to do that with each other. We have to model it and role model it. And we forget and we don't do that. And compassion in the workplace is sadly lacking in a lot of cases.
So I love involvement. I love engagement. I'm a massive fan of co-production. Like I'm in. You brought me in. I'm up for it. Problem is, sometimes you don't have the time to do it properly. Sometimes you're engaging with individuals who don't trust the services, that haven't had a great lived experience, or feel that the people that are having the conversation don't represent them. How do we then navigate that? Because that's really important too, isn't it?
So that comes back to one of the core principles of being trauma informed. It comes back to relationships. And actually the best people to do the co-production are the people that have the relationships with our population. So I don't do much face-to-face co-production work anymore. I used to do it all the time. I don't do a lot of it now, but I still co-produce my work, because I do that by working with my partners and stakeholders that have those relationships, and I work with them to do the co-production, because I don't want to cause more harm. People don't want to share their stories with strangers, and they don't want to share their story over and over and over again. So we have to work with the people and the organisations.
What are you saying to me, that people don't want to tell their stories over and over and over? Are you serious? Oh my days. That is brand new information.
And actually, we can sometimes be like thieves. We can steal people's stories from them and not give things back. And that is very harmful. So if we're going to co-produce with organisations that already have those trusted relationships with their population, so that they can feel heard, they have already understood, and that they then have that safety to be involved.
So it's not necessarily the message, but the messenger. And Sharon Moore, who's an absolute legend, has put in the chat a really important point about building confidence in communities. And the "you said we did," which is a very radical concept, I know, people, which is if someone has given up their time to come and share their lived experience with you, that it might be a bit courteous to just sort of let them know how that impacted change. But that's your bread and butter, isn't it, George? That's how you roll in Health Watch, right?
Yeah, so it's a big part of how we operate, is that we make sure we at least feedback to people what we've heard from them. And, you know, for example, with the focus groups recently, just a thing I really focused on was feeding back the notes that I'd written from the sessions and what people had told me. So there was opportunity to feedback on, you know, misrepresentations or misspellings or anything that they felt was missing, because sometimes you suddenly think of something afterwards. And being able to put that into a format that people can understand as well. Because a lot of, you know, with strategies, for example, we will produce a really long, quite complicated document that if you then went back to the public and said, this is what we've done with your voice, 9 times out of 10, probably even lots of colleagues are not going to read it, because it's so complicated and difficult to understand. And there was a really good point made in the focus groups around having an easy read strategy for everybody, because it's so much easier to read easy read for everybody, and there's lots of people who need easy read formats. So that would be a really key suggestion, is making the strategy easy to read.
So, George, you're getting a lot of love in the chat for your work on advocating for the needs of others and your work on the engagement so far. But the other thing I want to say, and a shout out to Ali Bishop, who's just put some stuff in the chat, is we're really clear about our aspiration to make sure that our EDI strategy is very short and very focused. It might be even interactive, as she says, as a radical concept, because if you want to know more, you can link in and you can find more. But quite often people just want to know what they need to know. And that's really, really important. And who has got the time for bedtime reading of a 96-page strategy, which is quite often how I spend my days. Do you want to come back on this, George, before I go to Colin?
So I just kind of add around what Emmeline has said around asking people how they want to be consulted. And there was a really good example where Leedsgate do kind of craft activities whilst they sit and chat to people, and there's really innovative ways you can do it, but we do tend to revert to kind of surveys and things that are, you know, easier to collate data, but it's really important to look at how we can support people to be involved and focus on those voices that get heard the least as well.
I mean, there is, and I am a massive fan of my comms and engagement colleagues because they are very good at what they do. And one of the things that they always do is look at what conversations we've already had and what do we already know before we start remixing the same song. So very not how we roll in West Yorkshire, but I appreciate that that might not be everyone's lived experience. Now, Colin, I am sure that the social media channels are going nuts about this question. What are they saying? Ooh, I like this. I like this. So continue to make sure our senior managers continue to reach out and hear local people. Absolutely. Patient's voice at the centre of everything we do. Some great stuff there, Colin. What are your thoughts?
It's reflecting on kind of what people are saying, making sure that we listen to different views and acknowledge them, and looking closely at who's not in the conversation as well. So making sure that if people are missing, that we're seeking them out and going to where they are.
Yes.
Going to where the communities are to listen to them.
I mean, another radical notion of going where people already congregate, where they feel comfortable and where they feel safe. I don't think we've ever done anything like that before. I mean, you know, you could always look at the way in which we delivered the COVID vaccinations, where we went to faith venues and used trusted influencers to amplify messages. I mean, I don't think we've done anything like that before, have we, folks? Clearly, some really radical suggestions on the Slido. Thank you very much, Colin. Now, John, I'm really mindful that sadly we started late and we only had you for a limited amount of time because you are a man in demand. Do you need to leave the podcast? If so, I will give the floor to you for any final comments before you depart.
Yeah, thank you very much, Fatima. I'm really sorry I'm departing. You know, I would have stayed as much as possible if I could. I suppose my only departing voice is around authenticity and truth. I think in the work of social care and healthcare, you know, things will not always be 100% right. We will get it wrong more than once. We just need to understand that we treat that with compassion. And when we make mistakes, that we learn from them. And we're not perfect. But if we're doing this truthfully with authenticity, I think the people that we care for, you know, our West Yorkshire kind of clients will understand that it is when we don't do that that people get really, really, really anti, and then it's much harder to kind of embed solutions. So yeah, let's just do it with compassion and authenticity. I'll leave you with that.
Oh, very wise words from a very wise man. Thank you, John Ebo. I also feel compelled to acknowledge, because there's a lot of noise in the chat, that no, we will not be writing a 96-page EDI strategy. I was reflecting that often strategies are long, but ours will not be. So please stand down, social media people, stand down in the chat. There will not be a 96-page strategy, because who wants one of them? I certainly don't. Just going back to what John was saying, George, I mean, I think we have to acknowledge that sometimes when things go right, it is not due to the intent of staff or colleagues that are working in our health and care services. Most people come into work with the best of intentions, but sometimes they find it really hard to advocate or support people that have different experiences to them. From your work in Health Watch, is that something that you've heard, and what advice would you give to our colleagues and our staff who sometimes struggle with that challenge?
I think kind of advocating for others and being an ally is really about asking people how they want to be supported and advocated for, and not making assumptions around that. You know, a key example from lived experience is around gender. People get quite stressed around the topic of gender and how to get pronouns and language right. But actually, if somebody asks me or somebody else, that can often help with that feeling of awkwardness and maybe avoiding the topic, and I can support someone to advocate for someone like myself. And I think people like to be asked around how they want to be referred to. Lots of people talked in the focus groups around language, around things like mental health, particularly around words like personality disorder and language that can be really, really negative and quite traumatizing for people. And I think if you haven't had that lived experience, you wouldn't maybe have that same connection to that language. So it's asking people, how do you want me to talk about you? How do you want me to support you so that you can do that in the best way possible? Which again, obviously sounds like a really simple concept, but I think we worry about being experts on everything, and we should just ask people.
I think that's a really important point, and what you made me think about, George, is we have all got people in our lives that we love, right? And at some point in our lives, we will also become patients. And sometimes we kind of forget that people that are using our services are just like us. And the little acts of kindness can often be free, but are often priceless. So there's just something about how we do that. I think there's something as well, just coming to your work, and the trauma informed work that you do, that sometimes some of the roles and services that our colleagues deliver are really hard. Like if you think of palliative end of life care, working with children and young people with life limiting conditions, yeah, that's really tough stuff. Supporting people with mental health conditions, really hard. What are your thoughts on what George has just shared?
I think what George has said is spot on. We're experts in ourselves, and we
Yeah.
forget that. And people forget that, and you get professional preciousness where people think they know better for you, and don't ask you. And we love to give labels. The only labels we should have are the ones we give ourselves and choose to use. And we do a lot of work around that in the trauma informed programme. And we have some guidance actually that Lisa Cherry developed with us, with colleagues across West Yorkshire. We've got some trauma informed language guidance. And it's absolutely what George said. Language is something that is very close to people, has different meanings. And a word that might be absolutely fine for me, I might use it every day, could be completely harmful to somebody else. So I think it's not about us saying, don't use this language and don't use that language. It's about us understanding that language can be harmful and it can be healing. And once you know what you know, you then have a choice, and that becomes a different conversation. In relation to our staff, they have I was saying this morning on the trauma informed training, we're probably seeing at the moment across our system the biggest burnout and vicarious trauma of our workforce than we've ever seen before. Legacy of the pandemic, the economic crisis, the racism that we're seeing in our system, and everything else that's going on. And actually, we need to be looking at how we address that. How do we address vicarious trauma? Because then what we get is compassion fatigue. And when we get compassion fatigue, professionals start making assumptions. They start giving labels. They start, they lose their empathy and compassion. And it's not because they don't care. Like you say, Fatima, none of us do this job to come and harm people. But actually, they themselves are in that intolerable stress place. And so you get compassion fatigue, you get burnout, and then people go off sick. So if we want to make a difference, we have to work with our workforce. We have to support the people that are caring for others, because if we don't do that, we're never going to make a difference. And I will always say that. And vicarious trauma is a real thing. Vicarious trauma, compassion fatigue equals burnout.
But I think one of the reasons why this agenda is so important for our equality, diversity and inclusion strategy is because if we don't have an inclusive workforce, that impacts on the quality and safety of our services. So we need to support our colleagues to be inclusive so that we're delivering high quality, safe services. Part of that requires them to be trauma informed. Part of them requires them to be culturally competent. But part of it requires us to support them to go on that journey.
And those
You
two
know?
things are separate, Fatima.
No, I don't think they are.
I can't even say it now. It's been a very long day. Being culturally competent is part of being trauma informed.
Yes.
If you're not culturally competent, if you're not inclusive, you're not trauma informed.
Well. And
Exactly.
It's part of our workforce, people plan. It's part. I mean, this is the thing. I think inclusion, and I haven't forgotten, George, that you want to come in. I'll bring you in a minute, but I really want people to get the penny to drop, right? I think true inclusion, equity, social justice is like good people management. We all do it, but when you need the experts, you go to the experts like Sharon, like Ali, and other folks across our system. But when you need to do it on a day-to-day basis, that's your job. And you see it as part of your job and you're owning it, because it makes you a better staff member, it makes you a better carer, it makes you more inclusive as a manager. I mean, for me, it's a no-brainer, but then I'm from a parallel universe. What do you think, George? Do you think I'm from a parallel universe?
That wasn't the question I was expecting you to ask me. No, not at all. I think
it's been a really long day, George.
Yeah, that's throwing me off. I think a key thing kind of related to everything we've said as well is creating that culture of being open to feedback and open to shifting your approach and changing the way you do things. I know when I've worked in frontline services, some stuff works for people and the same approach doesn't work for others, as we know, because people have different needs. And a really key thing that has always helped when I've been using a service is somebody saying, if at any point this doesn't feel like the right approach or I use the wrong language, or you want to change the way we're doing things, just let me know. And it's that permission to give that feedback in the appointment with somebody, rather than feeling like you need to raise a complaint or a concern, or kind of having to do things more formally, giving the option for somebody to say, actually, I know I said originally I wanted to do this, but I'm not sure now, and now maybe I want to do this instead. And it's that consistent check-in with people that it's the way that they want things to be done. And I think that's maybe the fear that we have as a
right. Exactly.
Yeah.
And I'm sorry to interrupt you, George, but I thought you were making a really great point, which is people don't know what they don't know. And sometimes they undertake and they learn things on the job, but unless they've encountered someone from that heritage or with that lived experience, you're not always going to be able to cater to those needs unless you ask those questions with appreciative inquiry, right? But there's some really great stuff about intersectionality and really recognizing, and we had this in the face-to-face session a couple of months ago, that people are not defined by a tick box. Right, so I'm here before you now, a slightly crazy woman of a certain age, from a certain faith, living with a disability, occasional wife, and a mother of a couple of children. I tick multiple boxes. Intersectionality is the embodiment of me. And what we're sort of saying is the approach of looking people through one lens at a time doesn't work, which is why that trauma-informed, culturally competent, inclusive approach is so crucial. But Ganesh, you know from your lived experience that sometimes people don't always feel comfortable approaching services or using services because they don't look like them, or they don't trust them because of their own lived experience. And sometimes they don't always give the feedback of when things don't go right. As somebody that's an advocate for people in communities, what advice would you give to someone who feels like if they came and shared their lived experience, they wouldn't be heard? How could we be better at that?
As you know, Fatima, even recently I came to you as the chair and said we've got to start looking at data properly because communities are saying one thing, and actually when we're saying we're in our roles, we're not really hearing what's going on. And to break down that, to actually break down those barriers of trust, I don't know if I think we're a very long way from that, especially with some certain communities. We're so far away from the trust levels. And I and until we have those people that look like us representatives and can communicate with us the way that we communicate in all of the structures and systems that we have from top to bottom, that's not going to change. But
Yeah.
also, I think what's really exacerbated things and made things so much worse for our communities, but then also for our system because of that whole lack of trust has been the cuts, has
Yeah.
been then clinical processes that
Yeah.
say that dictate because of the cuts, this is what we've got to do and this is how we've got to do it. And because of the pressure on staffing within our health and care and everything else, there's so many complex you talk about the word intersectionality, but actually within the system, this is so complex right now. And it has got a lot to do with the fact that we've had all those cuts for the past 11, 12 years, that the life expectancies have gone down, that maternity is an issue where it comes to diversity, where especially when it comes to women of colour, where communication is a problem. You know, if you don't understand a woman that's is having maternity care and she can't understand you, how are you supposed to um, go through that most
Yeah.
life-changing event? Do you know?
Absolutely.
So it's really big, and I'm very clearly saying here that trust is an issue. No matter how much we're gonna try to hide away from it, it's never been more underlined to me than it
Yeah.
has in the last 6 months.
And I think you beautifully articulated why an approach West Yorkshire wide on equality, diversity, and inclusion, focusing on equity and social justice is so needed. So, Colin, and it's with great sadness that I asked this question, but over to you for the final bit of feedback from our interactive viewers.
It's mainly about having the courage to ask, listen, and then act on what people are asking for, and being visible and open and transparent.
Absolutely. So, although we have sadly come to the end of the live podcast, the conversation continues. So, these QR codes will be available on multi platforms of social media, Instagram, of course, X and LinkedIn. So, please circulate with colleagues and continue the conversation. Hopefully, if you found this podcast useful, we might consider doing one again in the future, she says. Although I'm sure Ben may not agree. A huge thank you to all our panelists for their contributions and staying behind so late in the day. And I hope that when you see the equality, diversity and inclusion strategy, whatever we call it, that it reflects your feedback and your contributions from today and throughout the conversation. So thanks everyone. Have a lovely evening, stay safe and keep that conversation going.